Hi, everybody. Good morning or afternoon, depending on where you may be joining us. My name is Matt, and first I want to say thank you so much for signing up for the webinar today and choosing to spend your time with us. I know this webinar was originally promoted as an hour long, but I think we're going to be able to get through it a little sooner. So just a few things before we start. This afternoon, you'll receive a copy of the slides, a recording, and then your CEU certificate. I have to make an adjustment for the time, but you'll receive that in the near future. So please be on the lookout for that. And yeah, let's get started. I'd like to introduce you guys to Colby and Leah. So they are our health plan team. They work closely with our health plan partners and some other large health plans in the industry just to discover some inefficiencies and help them with their processes. They're really our health plan thought leaders here at Provider Trust. So that's who you have on the line today to talk about how to leverage exclusion monitoring to protect your provider networks and control recoupment. So again, thank you so much for spending your time with us today. A little bit about us. We are Provider Trust here in Nashville, Tennessee. And we're happy to be here. We have several partners in the state, and we like to consider this really a hotspot for healthcare technology and kind of the healthcare capital of the nation here. So we've been here in Nashville for 10 years, and we believe that a smarter healthcare makes a safer healthcare. And the way that we follow through on that promise is that we monitor healthcare populations for health plans, large health systems, hospital systems, long-term care facilities to identify compliance and credential issues before they impact patients. And that's a little bit about us. So we offer these webinars on a monthly basis. The topics rotate monthly. We try to give you guys relevant and timely information because we believe that one of our core values is to help others grow and succeed. So we're very passionate about the educational side of healthcare. And we actually, if you go to providertrust.com, our resource page is very extensive. We have over 300 resources for the healthcare professional covering a wide variety of topics. There is certainly, hopefully, something of value to you in there. And we'll share links towards the end of this presentation where you'll be able to access that very easily. So on the webinar topic, we have two upcoming, November 27th. I know it's really close to Thanksgiving, but we wanted to get this in for our compliance and HR folks on the line, where we're really talking about how those departments can partner better for success in 2020. And then December 11th, our last webinar of the year, we'll be covering how exclusion monitoring can better protect patients. So make sure you sign up for those if you're interested. Those will also be for CEUs. So you'll be able to add that to your list of credits by the end of the year. A little bit about today's agenda. We will start, Colby will kick us off with exclusion monitoring, the good, the bad, and the messy, and then followed by protecting your provider network. And then we'll go into how exclusion monitoring can help you control recoupment. And then we'll wrap it up with the key takeaways for today's presentation, so you guys have something solid to take away and share with your colleagues. So I'd first like to start with our first poll. We have 3 today, and we're just curious a little bit about which team or department at your organization is responsible currently for provider network exclusion monitoring. And really, we're just trying to get a feel for whether that lives in SIU, provider data operations, any sort of government program coordinator position or anything like that. If you do choose other, we ask that just so we can get a better idea, if you'll just please fill in who that may be or which department that may be, just so we can kind of see the wide range of responses here. So we'll leave each poll open for about 30 seconds just to try to get as many people voting in as possible. And yeah, we'll just give you guys a few more seconds and close out and share the results. So no surprise here that compliance has the majority. Just really want you guys to get a feel for how your peers and other organizations are functioning, and where these responsibilities lie within their organization. So 55% in compliance is really kind of what we expected. So thanks for contributing to the poll. And again, we'll have 2 more throughout the presentation, and we'll be happy to share those results with you guys. So with that, I will kick it over to Colby to kind of open up and share with you guys about exclusion monitoring.
Perfect. Thanks, Matt. So as Matt mentioned, my name is Colby Shaw. I work specifically with our health plan partners here at Provider Trust, alongside Leah, who is also here in the room with us. I think I can speak for both of us when I say that we're excited to be here and get to talk to you guys today. For any of you folks that have been to our webinars in the past, these are probably some new voices and some new faces that you're not used to. But we figured when we heard that health plans were going to be a big focus, we asked if we could participate. So Matt and team allowed us, and we are excited to be here. So as Matt mentioned, we're going to talk about exclusions today, and then we're going to talk about leveraging exclusion monitoring to protect your provider network and ultimately control recoupment. So what I'm going to do is I'm just going to kind of set a baseline for us and just go through and level set on exclusions in general, what they are, where they come from, and really kind of what makes it difficult to monitor exclusions and to try to cover these requirements in an adequate manner. So first off, the reasons that exclusion monitoring is so important is just because fraud, waste, and abuse is really a huge problem nationwide. Estimates show that anywhere from 3 to 10% of the nation's healthcare spending can be attributed to healthcare fraud. So if we go kind of on the aggressive side of that range and we say 10%, it's about $365 billion a year. So obviously huge issue, something that we want to try to help tackle. And some of the most common examples of that healthcare fraud you can see right here. Phantom billing for unnecessary tests or procedures that weren't actually performed, upcoding or billing for more expensive supplies or procedures than were actually performed, excessive billing for more than 24 hours of services in a day, and even fake billing companies, phony pharmacies, things like that, that disappear after collecting reimbursement. So again, can take a lot of forms, can look a lot of different ways, but it's a big, expensive problem that we want to at least do our part in trying to help tackle a little bit. Okay, so like I mentioned, exclusions can kind of come from a bunch of different places, and they can also take on a bunch of different forms. Kind of where we see exclusions start are in a bunch of different areas. So they can start at the state level. They can start with licensure issues that can ultimately result in an exclusion. Healthcare related misdemeanor actions, healthcare related felony actions, all the way down to even defaulting on a student loan, right? So the takeaway here and kind of the headline is it's kind of the whole spectrum. They can come from all kinds of different places. Obviously, some of these are more serious than others, but all need to be addressed and all need to be acted upon if you want to adequately monitor your provider networks and all of your other populations. So when I say that there are exclusions that come from a bunch of different things, there are also, the thing about exclusions is they can live in a bunch of different places, right? So when we talk about monitoring exclusions, there are a bunch of different sources that you need to be monitoring where exclusions can live. So as you see over here, there's the 2 federal lists that I think people typically think of when they think of exclusions. There's the OIG, LEIE, there's SAM.gov. There are also 43 state Medicaid exclusion lists. That's 42 states that actually publish a list, along with Washington, D.C. And then we have some other lists that we would consider best practice for monitoring, which include Medicare opt-out, CMS preclusion list, and really various others. So it really just depends on the level of coverage that you want when it comes to your populations. And these are just a few examples of some of those sources. Okay, so again, just some more stats to get familiar with the map of exclusions and kind of where exclusions stand currently. So as you can see, that big number right there in the middle, there's about 213,000 total exclusions that currently exist when we're looking at those three main sources or those three main areas that we talked about on the last slide. You have the 2 federal lists and then the 43 state lists that make up the exclusions that currently exist, and they're spread pretty evenly between those sources. Some interesting things to point out about each of these different sources and kind of exclusions in general. So you can see right there of all the OIG exclusions that exist on that federal list, about 43% of those are related to a license revocation. So like we mentioned earlier, licensure issues ultimately can result in an exclusion, and they make up a big chunk of the exclusions that exist. Something else that is really important to know that a lot of folks don't necessarily realize is that states are required to report their exclusions to the OIG, and they're required to do so within 30 days. The problem is they don't actually typically report those within 30 days. The average time that it takes a state to report their exclusion up to the federal level is about 173 days. So the requirement is to do it within a month, typically take about 6 months or so. So if you think about that relative to providers, and you think about that relative to claims that could be submitted within that 5-month gap, that's a really big issue that makes it really, really difficult to address, right? Something else that's not, that doesn't show, or it does right here on the bottom right of the screen here, is that even though they're required to report their exclusions within 30 days, about 50% of all state exclusions never actually end up even making it to the OIG, right? So all that to say, it is extremely important to not just look at the federal list when you are trying to monitor for your populations. If you're doing so, then there is a very good chance that you are missing exclusions on all of these different state sources, and that you have providers who are in fact excluded that you would never know about. So that's why, as a best practice, we here at Provider Trust would say that at an absolute baseline, you need to be making sure you're looking at both federal lists as well as all of these state exclusion lists to know exactly what's going on with your network. Okay, so staying on the topic of all of these different sources and how it can be a little bit tricky to monitor. The problem with exclusions is that these sources, they provide information publicly for you to go out and find and use to try to identify exclusions. The problem is the information that they provide you is extremely limited and makes it extremely difficult to actually feel comfortable about the fact that you are finding exclusions for your folks. What we're going to focus on here is NPIs as a unique identifier. We know that especially within provider networks, especially if we're talking non-PAR providers, the information that you even have as a health plan can sometimes be pretty limited, but an NPI we would say is what we typically see as the unique identifier that folks have access to and are able to use. So what we've done here is we have taken a bunch of the different exclusion sources, both federal and state, and we have kind of mapped out how many of the exclusion records at each of these sources actually contain an NPI, okay? So you can see here, OIG, LEIE, and SAM over on the left only have 8% and 5% of their exclusion records with published NPIs. What that does is it makes it extremely difficult to actually identify a match with 100% certainty, because all they give you to go off of is essentially a name, sometimes an address, sometimes a date of birth, but there's no unique identifier that allows you to know with certainty that that's the provider that you're trying to identify, right? Some states do it better than others. I'll brag on my home state of Kentucky here for a second. Of all of the exclusions that exist on the Kentucky state list, 85% of those have NPIs attached to those records. So it makes it a little bit easier to search. Texas, on the other hand, of all of the exclusions that exist on that state Medicaid list, only 3% of those have NPIs. So again, without that unique identifier attached to a record, it makes it extremely difficult for you to go take your providers and find matches at these sources. So just to kind of hammer that point home a little bit more, this right here is an actual exclusion record or an actual screenshot from the Alabama State Medicaid exclusion list. So this is just a great example of the limited data that is provided by these primary sources. So if you're scrolling through this list and you have a Dr. John Smith, all that they give you here is a first name, a last name, sometimes a middle name, middle initial, and an exclusion date. And that's what they give you to work off of. So this again is just driving home the point that without having those unique identifiers tied to these exclusion records, it makes it next to impossible to actually identify and find those individuals within your network. Okay, so what this is right here is along the same lines. This is a real life example of how this plays out, right? So we'll look at this in 3 different areas. We'll start over on the far left side of the screen. And this is information that is provided by an actual health plan. They have first name, last name, actually have a good bit of information here. Date of birth, NPI, they have 10 license numbers for this, for Cynthia Ketterer. So you would think that they have enough information that they should be able to go out and they should be able to identify an exclusion if it exists. The problem is when you look at the next column there and you look at the primary source, which in this case is the Texas state list, the information there is much more limited, right? You have Cynthia Ketterer still, you have an exclusion date, you do have a license number, but the problem with a situation like this is there's no guarantee that the license number at the primary source matches any of those license numbers that the health plan has access to, right? In this case, they did not. The license numbers did not match up, meaning when they took Cynthia Ketterer with all the information that they had, went to the Texas state list and tried to find a match, none of those identifiers matched up. So there was no way to know for sure whether or not this was the Cynthia Ketterer they were looking for, meaning that they were in the clear, right? No exclusion matches up here. What we would consider best practice here and what we do at Provider Trust to ensure that we're getting these matches, right, is we take the exclusion record that you see in the middle and we take the exclusion records from all of these different primary sources and we enhance those records with augmented data. So what we've done that you can see down on the bottom of that far right column is we have taken an NPI and we have tied an NPI to the exclusion record from the primary source. Now what that allows us to do is instead of searching for Cynthia Ketterer by name and then hoping that we get a potential match and trying to work through it that way, we can one-to-one match up the NPI that the plan provided with the NPI that we have tied to the exclusion record, and we can return a result that says, we know with certainty that this is the provider that you were looking for, right? Takes out all of the uncertainty, takes out any of the time spent trying to identify a potential match, any of the concern there. So again, data is extremely limited, and this is what we would consider best practice is just having more data, right, than what is available at the primary source. So I've spent a good bit of time now talking just about exclusions, about what they are, about what makes it so difficult and to monitor for exclusions, and also what we would consider best practice here at Provider Trust for our health plan partners. So this slide, I won't read all of it for you. You can definitely just kind of scan through here, but this is kind of a conservative estimate to give you an idea of if you were going to take the approach that we would consider best practice for monitoring your providers, this is the time that it would take to do that for 1,000 providers on a monthly basis, right? So even just locating and downloading all of the different exclusion lists take up to 8 hours a month. When we start talking about searching for providers by possible nicknames, possible misspellings, changed names, things along those lines, you're looking at about 167 hours a month. When you add it all up and you take all of these things into account, you're looking at about 2.2 FTEs a month when it comes to the time spent to actually adequately cover this. So we understand here that this is kind of a bear to tackle, and especially on your own. So that's why we do what we do. So now I'm going to kick it over to Leah. I think she's going to run through a couple questions with you guys and then jump in specifically to how you can use this to help protect your provider network.
Great. Thank you, Colby. So there's just some questions we want to pose back to you all to get you thinking about your current process as we've talked about exclusion monitoring, and we're going to dive into more of how that looks and where it fits into your organization. And so I will put these back up at the end as we wrap, but just kind of some food for thought as we work through the rest of our time together. First one is pretty straightforward. Are you doing exclusion monitoring in-house or working with a vendor? If you're working with a vendor, are you manually verifying potential exclusions, or are you getting definitive matches back that you don't have to go through the determination and the research yourself? A little bit of what Colby was talking about on the previous slide. Some other questions of how often then are you screening your provider network for exclusions? We're going to come back to that one here in a little bit and talk more about that. How accurate is your provider network data? That's one that we know has been really with CMS auditing from provider directories and the accuracy of provider directories. It's created a more of a focus over the past at least couple of years that we've seen an uptick in the conversations we've had about that, and really just paying attention to which identifying data are you collecting on your providers? Are you collecting NPI? Are you storing that somewhere that is easy to get? Are you cleaning that up on a regular basis and ensuring that it's accurate information? So just another thing to think about, because as Colby mentioned, from the sources and primary sources and some of the inefficiencies with those sources and the lack of data, the better your data is, the better luck you will have with catching those exclusions earlier in the process. How are exclusions communicated across teams internally, and how quickly does this occur? So really, what's your process for if you have found something, who does it go to, where does it go, and is that something that's easy for people to view, the different teams to view? So I saw, for example, compliance may own exclusion monitoring, but provider network operations they may own the data and may have to actually make the changes in a system, or claims may have to then stop a claim. And how quickly does that information get from one team to the other in your organization when you're finding exclusions or not? And then lastly, do multiple teams have access to exclusion monitoring results and reports? And are you having regular cross-functional meetings about those insights? Something we've heard from the market is, from a best practice standpoint, is some of our plan partners are holding regular meetings with compliance and legal and provider operations to, at least on a minimum monthly basis, review what's found, identify processes, etc. So just some things for you to think about as we continue forward. And we are going to shift to another poll question with one of those questions I just put up for you, which is, how is your organization currently managing exclusion monitoring? So are you doing it manually in-house? Are you using a vendor which is giving you potential matches back, and then you have to do the rest of the determination and investigation yourselves? Or are you working with a vendor that's giving you confirmed matches back, saving you that verification time on your own? Or are you unsure, which is completely fine as well. It just helps us get a gauge, and it's great for just feedback. Perfect. We're going to let you all finish responding. It looks like we're close to final participation, and then we'll share the results back. Okay, so it looks like the majority of you are working with a vendor with potential matches in-house verification. That's not surprising. It's definitely a trend we've seen. And then it's kind of split between a manual process and working with a partner that is doing that verification, really taking care of the full process for you. So thank you for responding, and we'll keep going, and that's useful information, and I hope that's useful for you all too. So let's shift into really talking about protecting your provider network. It's helpful, I think, to start at thinking about the provider life cycle. So how do they enter your organization as a provider? Where do they go? Who touches it? What's that process? So there's the first step for a provider to enter a network, enter your health plan, is through the enrollment process. We know there's some disparity across the industry on that enrollment process being fully automated to pretty manual and anything in between. We've worked with some plans, and we know that there's a lot of effort going into automating that, really to speed it up, because it's a lengthy process, which obviously is frustrating to both the plan and the provider, because if they've determined that they are wanting to join your network, getting them enrolled quickly allows them to start seeing members. So it starts at the enrollment process. Then, of course, it goes to contracting, where you're negotiating rates, determining which networks that provider is going to be a part of. And then credentialing, which is really enrollment's basic at a base level. Does the provider have what they need to actively see members within your health plan? Credentialing is a more in-depth look. We also know that that can be a lengthy process, and that there's a lot of focus on speeding that up. Typically, we know that at credentialing is a lot of times where your first sort of exclusion check occurs. We do know, and we'll talk about this here the rest of the time, is that if you can check at enrollment for exclusions, it's going to close some gaps for you and save time on the contracting credentialing side if you don't want that provider to move any further. But at the credentialing timeframe, you get them credentialed, then they become a participating provider in your network, meaning at that point they are online in your provider directory, they can start seeing members, and then they can start submitting claims. And that process really works continuously unless there's something that interrupts that. Something that, as you all know, can interrupt that is if an exclusion is found at that point when the provider is seeing your members, at which point that would pause the process, hopefully sooner than later, which we all know isn't always the case, but the goal. And that would push that provider and that instance into SIU and or recoupment. So if SIU the investigation process does identify that, yes, we paid a provider a claim that they should not have received, then the recoupment efforts begin. And as we all know, and hopefully this is why you joined us today, that is not the desired goal, and preventing having to go after recoupment is where we all would like to spend our time. So the other piece that's not on this graphic is your non-PARs. Your non-PAR providers do not have to go through the enrollment, the contracting, or the credentialing processes. So you have not had any opportunity up to that point to check that they are active, valid, and legitimate, and are not excluded somewhere and should be submitting you claims. But nonetheless, you will receive claims from non-PAR providers who have seen a member that went out of network, and then you have to pull that into your process and review and pay claims. We know that some organizations have a process in place where they have the infrastructure to check if that non-PAR provider is excluded or not before paying the claim. But most often we are hearing that, unfortunately, just to keep the claims process moving, you are paying those claims on the non-PAR providers and then having to go back after the fact and double check and confirm if that non-PAR provider should have received that claim, if that's happening at all. And we've spoken to some plans who just don't have the systems or the bandwidth or the infrastructure to check their non-PARs on a consistent recurring basis to make sure that those providers are okay and are not excluded on any of those primary sources that Colby referenced earlier. So we're going to go to another poll question as we're thinking about what I just talked about, and that is, when is the first time that your organization screens a provider for exclusions? Is it at enrollment? Is it at credentialing? Is it at the time of claim? And when I'm saying this, I'm meaning more specifically your PAR network, not your non-PARs, or is that unknown? and we'll give you guys just a few seconds here to respond, and we'll be able to see kind of what's happening across the board. Great. I think it looks like we're got most people participating, so we'll share the results back. I'm not surprised by the responses. So it looks like the large majority is at credentialing, and then still a decent percentage of you are doing it at enrollment, which is great. And we're going to talk about where how important that is and why that's important here on the next couple slides. So I thought this quote that is from 2017 from Healthcare IT News was relevant given today's topic, and also just given a lot of the conversations I've found myself in with health plans over the last year. And that's the concept and idea of connecting prepay with postpay. So I'm going to read it. Basically, it's traditionally employed post-payment recovery approaches to overpayment management can be augmented with prepayment solutions to achieve meaningful payment integrity. That is a mouthful, but basically what this is saying, and the point that this is getting across, and we tend to agree here, and that's the stance we take, is that if you can move your screening approaches up in the payment process or the provider life cycle, the results of that will be better payment integrity, which means you will be saving money from not paying out claims to providers who should not be receiving those claims. And you'll also be saving your team's time and energy not spent on recoupment and actually being spent on other investigations that are important and necessary work outside of just simply the recoupment investigation. So something I thought is interesting, and it's very much a trend in the industry that we're seeing across health plans. Now, talking a little bit more specifically on where you're screening and when you're screening for these exclusions, and then how that relates to recoupment. So provider enrollment screening, as I mentioned, is the first opportunity really for you to screen a provider as soon as they're sharing information with you on joining your network. What should that look like, or what can it look like? So if you're screening them at enrollment, you're basically able to identify, does this provider are they free and clear from showing up on any exclusion lists? You are able to do that because you will have the provider and PI, you will have their name, you'll have some basic information. And what we've seen across certain organizations that we've worked with is it works great in an online process. And I know, like I said earlier, that plans are really trying to work towards, and CMS I know is driving it, is trying to work towards online and streamlining your provider enrollment processes through online forms because it's quicker. And what that also allows, and how we work at Provider Trust with those plans that have that online enrollment process, is we can actually hit exclusion source data. So the exclusion sources that Colby talked about earlier, so those state and federal lists, you'll see some of those listed here, the Social Security Death Master, preclusion list, CMS ordering and referring list, we can hit that information immediately and return instant results within your process, within your online forms, not within our own ecosystem. And so that you've got immediate feedback and results to be able to determine, can this provider move forward in the enrollment process? Do you need to pause it and take it and investigate further, or does it need to stop altogether? So as we talk about that, and as we talk about how the enrollment and the credentialing and when you do checks and how that matters, it really leads us to kind of our final section, which is talking about controlling your recoupment. So if you're doing this right along the way, and you're doing it at the right moments in time along the way for both par and non-par, then ultimately the goal there is to control recoupment and reduce your recoupment efforts. So we've got a couple of case studies that we want to share that are, I feel like, very meaningful, relevant, and impactful, taking health plans that we've worked with and showing how their processes and using automated processes and NPIs have really identified areas where they can save money and save time. So the first one is for a client, a health plan that's got roughly 750,000 providers across multiple states, across Medicare and Medicaid networks. At the time, before they were partners of ours, they were manually checking against the OIG LEI list for their provider population on a monthly basis. So it was pretty limited in scope to the federal list. And at that point, they had no confirmed exclusions. When they came to work with us, we took that data, provider network data, and we were able, really upon activation, to find 1,500 exclusions. Part of that comes from the expansion of not only just checking the federal lists, but also the state lists, which, as you heard Colby talk about earlier, is really important, and we can't stress that enough, because you cannot trust that everything that is being published at the state list makes it to the OIG and vice versa. So part of it was the expansion of sources that we were checking, that we found providers in their networks were showing up on. And the other was the fact that we were, as you've heard and you've experienced and you heard Colby talk about today, the primary source data is not always complete and does not give you enough information to make a determination. What we are doing at Provider Trust is taking additional identifiers, where you saw that NPI example, and we're able to find exclusions that you would not necessarily be able to find on your own if you're simply manually checking your roster against those lists. And then there forward, we found for the next 6 to 12 months of the partnership, at least, we found an average of 28 exclusions each week. And some of that was they're a rapidly expanding organization. And it was just a way that we were really preventing in real time for them allowing providers to be in their network that should not have been in their network and that should not be getting paid reimbursement. So that said, that's a pretty practical example of, if you're checking the right things at the right time using the right data, you can reduce your claims payments, therefore reducing recoupment efforts and recoupment costs. The next example is a little bit different than that first one. And it's basically, we took two full states, provider network information for 2 full states using only NPI. So that's important in this instance, especially if we're talking about non-PARs. And even non-PARs, sometimes if you only have, at the time of claim, you may only have an NPI, whatever that might be. This example simply took NPIs and was the result of a real-time screen. So where we started was with roughly 145,000 providers. We also got claims data just as part of the demonstration to just demonstrate some actual real cost savings. So you'll see in the blue boxes as we go along with this example, the claims data associated with that example. So 145,000 providers, $1.46 billion in claims. That resulted in about 3,000 flagged providers. So we scrubbed it down and found 3,000 flagged providers. Those flags were distributed across a few different areas. On the left, you see it was 416 excluded providers that came out of that 3,000. 1,600 had inactive NPIs. 911 were found on the Medicare opt-out list. And as you know, sometimes that's relevant and meaningful, and sometimes that's not. It depends on the network and the, what type of patient visit they're seeing. And then there's 36 invalid NPIs. So we're going to focus in on the 416 excluded providers and see what that netted out to be. So what that was 288 were current exclusions. 134 we were able to find in the data were actually reinstated, and then there was 1 waiver. So the 288 current exclusions are clearly what this organization needed to be worried about and needed to focus on, because they did not want to be paying claims to that group. So what we found, and this is really amazing, I love this story, is that there was 171 that were a primary source match. So it's $422,000 in claims. What that means is if they would have gone out and been searching their roster against primary sources, they would have found that 171. 117 of those 288 came from the result of our augmented data, so using additional data identifiers that were not publicly available at the source, and identifying that those were in fact excluded providers that existed in these networks that clearly they did not want to have existing in those networks. So that's roughly 40% of the population we were able to find as a result of that scrub. And again, I can't stress this enough, that was only using NPI. When we're checking for PAR networks, a lot of times we have names, addresses, socials, and NPIs. So there's even more opportunity to find, to make determinations in an expanded manner. But for non-PARs, using an NPI and doing a one-time run is a really powerful exercise, and something we do a lot for our plan partners as they determine the frequency at which they want to handle their non-PAR networks. So that's a lot. I'm going to, as we wrap up, I'm going to go back to those questions that I asked you earlier, just to kind of let you see them again and have you think through those. We've got some time to take questions. I know we're getting a few questions in online. So as we look at the questions, I'm going to leave this up for you to take a look at.
Great, thanks Leah and Colby. We do have a few questions here, so please chime in if you come up with a question over the next few minutes, and we'd be happy to answer. And if we are unable to answer, we will be happy to find you the answer. So we have 3 questions so far. Our first question comes from John. He says, can someone be excluded at a state and federal level, or are they mutually exclusive? Colby, do you want to take that one?
Yeah, absolutely. That's a really good question, and something that we talk through quite a bit. So the answer is yes. An individual can be excluded on several different sources at the exact same time. They are not mutually exclusive. So you can be excluded solely at the federal level. You can be excluded solely at the state level. And as we mentioned, sometimes, even though it's supposed to, that state exclusion might never even make its way to the federal level. But at the same time, yes, you can be excluded at the federal level. So on the OIG, you can be excluded in a state. You can be excluded in 7 states. They are not mutually exclusive as it relates to where an individual can be placed. Great question.
Thanks, Colby. Second question is from Mary. She asks, should PAR providers and non-PAR providers be handled the same way?
Yeah, I'll take that. Good question, and one that we get asked quite a bit. So that really varies based on organizational preference and how you handle them, even where do you keep them system-wise, and what kind of data are you collecting on each. What we've seen typically is that the frequency of which they are checked can vary, and that is pretty common. So perhaps you think that, non-PARs, maybe you want to do a monthly or quarterly scrub of anybody that you've paid claims to on a rolling 12-month time frame, or just in the past month. And we see that data, a lot of times the non-PARs come over to us at a different frequency, but we absolutely feel very strongly that non-PARs are an area of risk and an area that you can save money. It's an opportunity to save money from a recoupment standpoint. And so, like I mentioned a little bit ago, as long as you have an NPI, which you do for a non-PAR, they can easily be screened, if it's just once a month, once a quarter, whereas your PAR providers they're a higher volume of claims. You want to pay more attention more frequently to that group. And on the PAR side, we're typically getting updates to that information daily or weekly from our health plan customers, whereas non-PARs, perhaps that's just on a monthly frequency.
Yeah, I would say headline there is they're just very different populations, right? Your PAR providers and your non-PAR providers. And there are ways, there are solutions, there are processes that can be tailored specifically to address the obstacles that both of those populations present.
Great, thanks guys. And as we wrap up here, I do want to say thanks again so much. Actually, we have one final question that just came in, so we're happy to give this a shot. Nadia asks, if money was paid to a non-par excluded provider, what due diligence is required of the MCO in recouping the funds if the non-par provider is unresponsive to the recoupment request?
Nadia, good question. And I can take a stab, but I would prefer to actually touch base with our compliance officer who's not on the call today, because my experience tells me that actually varies from plan to plan based on some of their risk tolerance, but I don't actually know the specific answer on the the compliance requirements and implications there, and so I don't want to lead you astray, but it's something we can follow up with you on, Nadia. Definitely appreciate the question.
Awesome. Well, thank you all for your questions and your participation today. We feel very lucky to be able to spend this time with you. We value your time, and we know that you all are very busy. So thank you so much for choosing to spend your time with Provider Trust this afternoon. This presentation and a copy of the recording will be sent to you this afternoon. We have to make a slight adjustment to our CEU application for time, so be on the lookout for that to come shortly. And this entire presentation is actually clickable, so all the links you see you'll be able to use once you receive it. So again, on behalf of us, Colby, Leah, thank you for being here today. We just want to say thanks for joining us, and we hope to see you next month. I hope you all have a great rest of the week.